3, and today we are going to discuss the different types of hemolytic anemias and how to approach hemolytic anemias in children. So first of all, the learning objectives, today's learning objectives are what is hemolysis, what are the types of hemolysis, classification of hemolytic anemia, approach to child with PELAR, and diagnosis and management of different types of hemolytic anemia. So what is hemolysis? Hemolysis is defined as a premature destruction of the red blood cells, and anemia results when the rate of destruction exceeds the capacity of the marrow to produce the red blood cells. Okay, before we move forward, I just want to tell you that I will take your questions and answers in the last 10 to 15 minutes of the session. So if you have any questions, you can write it down with yourself, and then at the end I will ask you what your questions are, and we'll answer them, inshallah. So the normal RBC survival time is 110 to 120 days. That is, half-life is 55 to 60 days, and approximately 0.85% of the most senescent RBCs are removed and replaced each day. So during hemolysis, RBC survival is shortened and the RBC count falls, erythropoietin is increased, and the stimulation of the marrow activity results in heightened RBC production reflected in an increased percentage of reticulocytes in the blood. That's why when in cases of any hemolysis, when we are suspecting hemolysis in a patient, we will, along with the CBC and peripherismin and the other tests, we'll also advise, or we will also check the retic count, because reticulocytes are the premature red cells that are immaturely released into the bloodstream when there is increased hemolysis. Now, the types of hemolysis. There are two types of hemolysis: extravascular hemolysis and the intravascular hemolysis. So the extravascular hemolysis is mediated by the reticular endothelial system of the spleen and liver, and most hemolytic anemias such as warm autoimmune hemolytic anemia, sickle cell disease, and hereditary spherocytosis are characterized by extravascular hemolysis. So this type of hemolysis basically takes place in the organs of the reticular endothelial system, that is spleen and the liver. Now, the hallmark of the extravascular hemolysis is the phagocytosis of the erythrocytes by splenic macrophages or the hepatic Kupffer cells, followed by sequestration and the removal. And the heme released from the free hemoglobin in the phagocytosed cells is converted to biliverdin within the phagocyte. Biliverdin is subsequently converted to bilirubin, and that's why in cases of hemolysis, we also get the hyperbilirubinemia because of the increased red cell breakdown, heme production, and ultimately bilirubin is a byproduct of the heme. Then the second one is the intravascular hemolysis, and it is defined as the damage incurred by the RBC membrane directly within the vasculature due to shear stress, toxins, or complement mediated lysis. Examples include mechanical valve-induced hemolysis, Shiga toxin-associated hemolytic uremic syndrome, and cold agglutinin disease, and the G6PD deficiency. All these will take place within the intravascular compartment. Now, whereas the hemoglobin clearance occurs within the macrophage in the extravascular hemolysis, during intravascular hemolysis, the circulating free hemoglobin is bound irreversibly to the plasma haptoglobin and cleared by the liver. If free hemoglobin exceeds the binding capacity of haptoglobin, hemoglobinemia occurs. Unbound hemoglobin dimers are reabsorbed by the proximal renal tubule until the absorptive capacity is exceeded, and the free hemoglobin is subsequently excreted in the urine, which appears dark. There is hemoglobinuria in cases of intravascular hemolysis. Now we come to the classification of the hemolytic anemia. So we classified into four different categories. First one is the hemoglobinopathies, which include the alpha thalassemia, beta thalassemia, sickle cell anemia, and the hemoglobin E disease. Then there is a long list of other hemoglobinopathies, but these are the common ones. Then comes the red cell membrane RBC enzyme defect, that is G6PD deficiency, and the pyruvate kinase deficiency, which are the commonest one. Then comes the RBC's membrane defect, that is hereditary spherocytosis, elliptocytosis. There are other defects as well, but these are the most common types. And the last one is the acquired hemolytic anemia, which is the immune hemolytic anemia. Now, hemoglobinopathies. Hemoglobin is a tetramer consisting of two pairs of globin chains. Abnormalities in these proteins are referred to as hemoglobinopathies. The normal adult hemoglobin consists of two alpha and two beta chains, and they can be further classified into qualitative and the quantitative defects. And the qualitative defects are the one in which the hemoglobin, there is a defect, one of the amino acid within the hemoglobin chain is missing, or it is replaced by some other amino acid, while in cases of the quantitative defects, whole of the chains are missing. Like alpha and beta thalassemia result from decreased production of the alpha and beta chains. This is the quantitative defect. While qualitative defects include sickle cell disease, hemoglobin E disease, hemoglobin D disease, in which one there is the globin chains are the quantity is normal, but there is a defect within the chain, and one of the amino acid, like in case of sickle cell disease, valine, the result from amino acid changes in the globin chain, like in hemoglobin S, amino acid glutamine is replaced by valine at position 6 of beta globin chain. So this is the qualitative defect. By alpha and the beta thalassemia, in which there is the defects of the alpha or beta chains are missing, whole chains are missing, they are the quantitative defects. Now in beta thalassemia, children present with PELA are usually presenting at 6 months of age, associated with features of extramedullary hematopoiesis like hepatosplenomegaly, frontal and parietal bossing, and the maxillary hyperplasia. It is an autosomal recessive disorder, and clinically it can be classified into two syndromes like thalassemia major and thalassemia intermedia. Now, thalassemia major and thalassemia intermedia are basically are the clinical syndromes, and there is no difference in the lab reports. The lab reports and the hemoglobin electrophoresis reports will be the same, but it is basically the clinical presentations or the phenotypes of the patient that is different in both these syndromes. In thalassemia major, the patient usually present at around 5 to 6 months of age, and they need frequent blood transfusions, and the age of presentation is earlier and the severity is marked. While in case of thalassemia intermedia, the symptoms are not as severe as in major, and the age of presentation is also sometimes late. And what causes the difference in major and intermedia is the type of mutation. As in cases of thalassemia, we know that there are different types of genetic mutations which results in thalassemia syndromes, and these mutations basically affect the clinical phenotype of thalassemia. Now, how are you going to investigate a child with the suspected case of thalassemia major? First of all, we'll go for the CBC, which shows anemia, and then we go for the peripheral smear, in which there is hypochromia, microcytosis, coagulocytosis, target cells, and nucleated red blood cells. The reticulocyte count usually is not very much just because of ineffective erythropoiesis. Now, what happened in cases of acute hemolysis like the G6PD deficiency, immune hemolysis, the bone marrow is under stress and it produces immature RBCs that are released immaturely into the circulation, and we get the increased retic count. But in cases of thalassemia, there is ineffective erythropoiesis. Means that the red cells that are formed are actually destroyed within the bone marrow. So that's why the reticulocyte count is not raised, because the erythropoiesis is not as much effective as in cases of other hemolytic anemias, because the red cells are destroyed within the bone marrow. The diagnostic test or the confirmation diagnostic test for thalassemia is the hemoglobin electrophoresis, and in hemoglobin electrophoresis we get the hemoglobin F. of more than 90%. Now, in normal HB electrophoresis, we have two types of hemoglobins, hemoglobin A and hemoglobin A2. And A2 should be less than 3.5%, while hemoglobin A should be more than rest of the hemoglobin should be hemoglobin A, and F is in traces or absent. So this is the normal hemoglobin electrophoresis report, in which we have two types of hemoglobin, hemoglobin A and hemoglobin A2. A2 should be less than 3.5 and the rest should be hemoglobin A. In cases of thalassemia major, what happens that since there is deficiency of beta chains, and as you know that hemoglobin A comprises of 2 alpha and the 2 beta chains. So when the beta chains are not there, so what happens that the excess alpha chains, they combine with the remnants of the gamma chains. And there is an the combination of the alpha and gamma chain results in hemoglobin F production. And that's why in cases of thalassemia major, hemoglobin F is raised and it is usually more than 90%. So in thalassemia major, the electrophoresis report will show F of more than 90%. Hemoglobin A can be there or it can be absent. It depends on the type of mutation. As I told you that the phenotype and other things depend on the type of mutation. And there are two types of mutations. One is the beta plus mutations and one is the beta not mutation. So in beta plus mutation, some of the beta chains are produced in small amounts, and this will result in a small amount of hemoglobin A. So in HB electrophoresis, sometimes you may get 5 to 10% of the hemoglobin A, but the major hemoglobin will be hemoglobin F. Then the further diagnostic test which is available for thalassemia is the genetic mutation for thalassemia. Now, in which cases we will go for the genetic mutation? Normally, or usually we go for the HB electrophoresis or the HPLC, and we don't go for the genetic mutation. But there are conditions in which HB electrophoresis cannot be helpful. Like if a patient has came to you with already having 2 to 3 blood transfusions. So now if you go for the HB electrophoresis, then it will not show the true picture because it will be showing the picture of the transfused red blood cells. So it will not show you the true picture of the patient. So in these cases, and you cannot wait, and you know the red cell lifespan is 120 days. So you cannot wait 120 days and keep the patient off transfusion to get this test. So in these cases, we have to go for the genetic mutation for thalassemia. And these patients require lifelong blood transfusions along with iron chelation. Bone marrow transplant is the ultimate cure with success rate of 70 to 90%. So the treatment of thalassemia major is the lifelong blood transfusions along with iron chelation. This is actually not the treatment. This comes under the supportive care. The definitive care is the bone marrow transplant, and ideally it should be done as early as possible before the patient gets more than 5 years of age and he has no liver fibrosis, iron chelation is optimized. Then in these cases, if we perform the bone marrow transplant, then the success rate is 70 to 90%. But if the patient already has a lot of blood transfusions and he has high serum ferritin, he has liver fibrosis or hepatomegaly, splenomegaly, then in these cases, the outcome of the transplant is not good and it is less than 50%. And we usually don't go for bone marrow transplant in such cases. And but as soon as the patient is diagnosed, we have to counsel the parents regarding the blood transfusions and the iron chelation. The iron chelation is the as important as the blood transfusion. Okay. Then we come to the sickle cell anemia. Now, the children with sickle cell anemia present with pallor, bone pains, chest pains, splenic sequestration whenever there is oxidative stress like infection and dehydration. These children are also at increased risk of infection with encapsulated organisms secondary to hyposplenism or autosplenectomy. Now, what happens that in hemoglobin S, Hemoglobin S, as we already mentioned, that the glucosamine is replaced by valine at position 26 of the beta globin chain. So what happens? This makes the hemoglobin S is vulnerable to sickling of the red cells, and whenever in cases of there is oxidative stress like infection and dehydration. Now, how are we going to diagnose it? Again, in the CBC, we start with the CBC. We get anemia. Peripheral smear will show hypochromia, microcytosis, poikilocytosis, and the sickle cell. And the HB electrophoresis will show hemoglobin S, which is more than 90% and more than 50% sickle cell disease. Now, what is the difference between sickle cell anemia and the sickle cell disease? Sickle cell disease is basically a heterozygous state in which the hemoglobin, one of the mutation is hemoglobin S, which comes from one of the parent, while the other mutation is of any other hemoglobinopathy like beta thalassemia mutation or E beta thalassemia mutation, hemoglobin E or hemoglobin C. So it's a heterozygous condition. So this is termed as sickle cell disease, but the clinical manifestations is more or less same. Again, in gray cases, we go for the genetic mutation where we are doubtful. Now this is the peripheral smear which is showing this sickle shaped RBCs, which are the hallmark of sickle cell anemia or sickle cell disease. Now, the treatment of sickle cell disease is the avoidance of the risk factors and hydroxyurea. Now, what is the purpose of hydroxyurea? Hydroxyurea is basically a myelosuppressive drug, but it has another effect, and that is that increases the gamma chain production and hence the hemoglobin F concentration. Since hemoglobin S has high oxygen affinity and therefore it prevents the sickling. Because hemoglobin S has high oxygen, hemoglobin F, this is not hemoglobin S. Hydroxyurea increases the gamma chain production and hemoglobin F concentration, and because of the increased hemoglobin F, and it has high oxygen affinity, and therefore it prevents the sickling. And these children also require regular vaccination against encapsulated organisms. So after hemoglobinopathies, we come to the red cell enzyme defects. One of them, most common, is the G6PD deficiency. G6PD deficiency is the most frequent disease involving the enzymes of the hexose monophosphate pathway, and it is an X-linked recessive disorder. The most common manifestations of this disorder are neonatal jaundice and episodic acute hemolytic anemia, which is induced by infection, certain drugs, and rarely the fava beans. Now, the most individuals with G6PD deficiency are asymptomatic with no clinical manifestations of the illness unless triggered by infection, drugs, or ingestion of the fava beans. Typically, the hemolysis ensues in about 24 to 48 hours after a patient has ingested a substance with oxidant properties. And in severe cases, hemoglobinuria and jaundice result, and the hemoglobin concentration may fall precipitously. Now, this, if you remember, at the start I told you that hemolysis of two types, and G6PD comes under the intravascular hemolysis, and that's why there is hemoglobinuria and jaundice, and the retic count will also be raised because it is a cause of causes acute hemolysis. And in the CBC, there is decreased hemoglobin or anemia, peripheral smear show reticulocytes and the veins bodies, and the G6PD levels in the RBCs should be done few days after acute hemolysis, since young newer RBCs have significant higher enzyme levels as compared to the older ones, and the less than 10% activity is considered deficient. Now, this is the peripheral smear of the G6PD deficiency patient, which is showing the veins bodies and the white cells. Now, what is the treatment? The treatment of okay, so these veins bodies are actually the denatured hemoglobin that are formed in cases of because of the G6PD, because of the hemolysis, and ultimately these denatured hemoglobin are taken up by the macrophages, and these white cells will result. The treatment is avoidance of the triggers, that is the we have to avoid the drugs which result in hemolysis in cases of G6PD deficiency patients. And once hemolysis occurs, transfusion of the red cells should be done. And in cases of neonatal hemolysis, exchange transfusion must be done to reduce the hyperbilirubinemia and prevent the kernicterus. Now, this is the list of the drugs which is causing hemolysis in G6PD deficiency. And whenever a patient is diagnosed with G6PD deficiency, we have to give the list of the drugs to the patient so that, and they should be carrying this list whenever they went to visit a doctor, because these drugs should not be given in these patients. Otherwise, it will induce hemolysis, acute hemolysis in such patients and result in severe anemia. Now, the list of the drugs include analgesics such as aspirin, phenacetin, antimalarials such as primaquine, pyrimethamine, quinine, chloroquine, and primaquine. Antibacterials such as sulfonamides, Dapsone, nitrofurantoin, chloramphenicol, and the quinolones. And there are certain other drugs like vitamin K, probenecid, quinidine, timercaprol, and phenyl hydrazine. So that's all about the G6PD deficiency. Now we come to the hereditary spherocytosis, which is a type of red cell membrane disorder. Now, hereditary spherocytosis is a common cause of hemolysis and hemolytic anemia with a wide spectrum of severity. It is the most common inherited abnormality of the red blood cell membrane, and the affected patients may be asymptomatic without anemia and with minimal hemolysis, or they may have severe hemolytic anemia. So the clinical condition again varies from person to person. Hereditary spherocytosis usually is transmitted as an autosomal dominant or less commonly an autosomal recessive. Mostly it is autosomal dominant, and you may get one of the parent affected. The most common molecular defects are abnormalities of the spectrin or ankyrin, which are the major components of the cytoskeleton responsible for the RBC shape, and our deficiency in spectrin, protein 3 or ankyrin results in uncoupling in the vertical interactions of the lipid bilayer skeleton, and there is a loss of the membrane microvesicles. And the loss of membrane surface area without a proportional loss of cell volume causes sparing of the RBCs and an associated increase in the cation permeability, cation transport, ATP use, and glycolysis. The decreased deformability of the spherocytic red cells impairs the cell passage from the splenic cords to the splenic sinuses, and the spherocytic red cells are destroyed prematurely in the spleen. And that's why splenectomy markedly improves the RBC lifespan and cures the anemia. So these are the spectrin, ankyrin, and the band 3 different proteins that are responsible for the red cell integrity. And whenever there is a mutation or defect in these proteins, there is a loss of the vertical interaction in the red cell membrane, and the normal biconcavity of the red cell is lost, and the red cells become spherocytic, and these spherocytic red cells are prone to damage whenever they pass through the splenic cords. So there is the red cell lifespan is shortened, and there is hemolysis. Hereditary spherocytosis may be a cause of hemolytic disease in the newborn and can manifest as anemia and hyperbilirubinemia sufficiently severe to require phototherapy or extreme transfusions, and the severity of symptoms in infants and children is variable. Some patients remain asymptomatic into adulthood, but others have severe anemia with pallor, jaundice, fatigue, and exercise intolerance. Now, the severe cases may be marked by expansion of the diploe of the skull and the medullary region of other bones, but to a less extent than in thalassemia major. After infancy, the spleen is usually enlarged, and pigmentary bilirubin gallstones can form as early as 4 to 5 years of age. And the cause of these gallstones is because of the chronic hemolysis, and chronic bilirubin protection ultimately leads to the bilirubin gallstones. And at least 50% of the unsplenetomized patients ultimately form gallstones, although they may be asymptomatic. Because of the high RBC turnover and the heightened urethral marrow activity, children with HS, hereditary spherocytosis, are susceptible to aplastic crisis, primarily as a result of pyrovirus B19 infection and to the hypoplastic crisis associated with various other infections. Now, what happens whenever there is an infection with pyrovirus B19 or some other viral infection that causes the bone marrow to affect? What happens that in normal patients, whenever there is such type of infection, the marrow recovers early. But here already the RBC turnover is high and the marrow is already compromised. So what happens whenever there is an hemolytic stress, the patient goes into the aplastic or the hypoplastic crisis, and the erythroid marrow failure can rapidly result in profound anemia, high output heart failure, hypoxia, cardiovascular collapse, and death. And the WBCs and the platelet count can also, that's why it is termed as aplastic crisis, that ultimately whole of the marrow is involved. Now, how are you going to diagnose? The CBC, we get decreased hemoglobin with raised MCHC of 36 to 38 gram per deciliter because the red cells are now spherocytic and their biconcavity is lost, so the mean corpuscular hemoglobin concentration is increased. Then the peripheral smear showed the poikilocytosis, reticulocytosis, and the spherocytes. The spherocytes are the diagnostic of HS. Spherocytes may be the predominant cells or may be relatively sparse depending on the severity of the disease, but they usually account for more than 15 to 20% of the cells when hemolytic anemia is present. Now, this is the normal peripheral blood smear in which these are the biconcave red cells with central pallor. These are the normal red cells, and they have a central pallor, which means they are biconcave. In cases of, now how the spherocytes will look like, because of the loss of biconcavity, the central pallor is lost. And these are the spherocytic red cells. So this is the difference. These are the spherocytes that are seen in HS. The presence of spherocytes in the blood can be confirmed with an osmotic fragility test, which is the diagnostic for HS, and that RBCs are incubated in progressive dilutions of an isoosmotic buffered salt solution, and exposure to hypotonic saline causes the RBCs to swell. Now, what happens? In osmotic fragility test, the red cells with spherical membrane are more fragile and they cannot withstand the hypotonic saline. And whenever how do we perform this test? I can show you with this picture. Now you can see that this is the normal curve and this is the curve of the HS red cells. Now what happens on the x-axis, you can see this is the normal saline or the salt solution concentration, and as we are decreasing the strength of the sodium chloride, like we are doing the hypotonics or increasing the hypotonicity, there is increase in the red cell lysis. There is increase in the red cell lysis. So these spherocytic red cells, they cannot withstand the hypotonic salt solution, and when they are subjected to the increasing strength of the hypotonic solutions, since they are very fragile, so they are hemolyzed. So this is a graph, and this is the control, which is of the normal red cells, and these are the spherocytic red cells. So this is the osmotic fragility test, which is used to confirm this. But it is not specific for hereditary spherocytosis, and confirmation can be done using SDS page electrophoresis, which identifies the membrane proteins. Treatment. The treatments with well-compensated hemolysis and no transfusion requirements need no treatment other than reassurance and folic acid supplements. While for the majority of the patients with autosomal dominant forms of HS and most patients with de novo disease, splenectomy restores the lifespan of the red cells to normal and hence cures the hemolysis and hyperbilirubinemia. Now we come to the acquired hemolytic anemia or the autoimmune hemolytic anemia. The most important immune hemolytic disorder in pediatric patient is hemolytic disease of the newborn, which is caused by transplacental transfer of maternal antibody active against the RBCs of the fetus, that is isoimmune hemolytic anemia. Various other immune hemolytic anemias are the autoimmune and may be idiopathic or related to various infections like Epstein-Barr virus, rarely HIV, CMV, and mycoplasma. Immunologic diseases like SLE, rheumatoid arthritis, immunodeficiency disease, lymphoproliferative disorders, neoplasms like lymphoma, leukemia, and Hodgkin disease. Now, what happens whenever there is any infection or any related to these viruses, our immune system is activated, and it leads to the production of the antibodies that will destroy these viruses, or they will restore the immunity. Now, sometimes what happens that these antibodies that are formed against the viruses or the pathogens that are causing the infection, and they cross-react with the normal or the self-red cells of the patient and produce the hemolytic anemia. So it is basically an immune dysfunction of the body. Then there are certain drugs as well, like methyl dopa, L-dopa, other drugs like penicillin, cephalosporins, which cause the hemolysis by means of drug-dependent antibodies. That is, antibodies are directed toward the drug, and in some cases toward an RBC membrane antigen. So the antibodies that are formed against a specific drug component, they will cross-react with the RBC membrane antigens and will result in hemolysis. Now, the autoimmune hemolytic anemias may occur in either of the two general clinical patterns. The first, an acute transient type lasting 3 to 6 months and occurring predominantly in children ages 2 to 12 years, account for 70 to 80% of the patient. It is frequently preceded by an infection, usually respiratory. Onset may be acute with prostration, pallor, jaundice, fever, and hemoglobinuria, or more gradual with primarily fatigue and pallor. The spleen is usually enlarged and is a primary site of destruction of the hemoglobin G-coated RBCs. So again, the spleen is the culprit, and the hemolysis takes place intravascular as well as the extravascular. The other clinical pattern was a prolonged and chronic course, which is more frequent in infants and in children more than 12 years of old. Hemolysis may continue for many months or years, and the abnormalities involving other blood elements are common, and the response to glucocorticoids is variable and inconsistent. Now, diagnosis: CBC will show the anemia, peripheral smear showed spherocytes, reticulocytes, and the nucleated RBC. So again, as you know, the spherocytes are seen in cases of immune hemolysis. So whenever you are seeing the spherocytes on the peripheral smear, you should think of two differential diagnoses. One is the HS, that's hereditary spherocytosis, and another one is the autoimmune hemolytic anemia. Now, how are you going to differentiate between the two? Once you get the spherocytes on the peripheral smear, you will immediately advise the patient the direct antiglobulin test or the Coombs test. And if Coombs test, which detects the antibodies against the red cells, comes positive, then it means that this is not HS, this is because of the immune hemolysis. Treatment: the transfusions may provide only transient benefit but may be life-saving in cases of severe anemia by providing delivery of oxygen until the effect of other treatment is observed. If the hemolysis is severe and results in significant anemia or symptoms, treatment with glucocorticoids is initiated. And glucocorticoids decrease the rate of hemolysis because it's an immune modulator by blocking the macrophage function by down-regulating the Fc gamma receptor expression, decreasing the production of the autoantibody, and perhaps enhancing the elution of the antibody from the RBCs. Prednisolone or its equivalents is administered at a dose of 2 mg per kg per day. And treatment should be continued until the rate of hemolysis decreases, and then the dose gradually reduced. If relapse occurs, resumption of the full dose may be necessary. The disease tends to remit spontaneously within a few weeks or months, and the Coombs test result may remain positive even after the hemoglobin level returns to normal. If prednisolone fails, then IVIG or monoclonal antibody rituximab can be tried. And splenectomy may be beneficial but is complicated by a heightened risk of infection with encapsulated organisms, particularly in patients less than 6 years. Acute idiopathic autoimmune hemolytic disease in childhood varies in severity but is self-limited. Death from untreatable anemia is rare. And approximately 30% of the patients have chronic hemolysis, often associated with an underlying disease such as SLE, lymphoma, or leukemia. Because these are also the autoimmune disorders, and they can also present with autoimmune hemolytic anemia. Now, after describing briefly about the different common types of hemolytic anemias in children, we'll discuss briefly how to approach a child with anemia. Now, first of all, we'll take the history. And in history, we'll ask history of pallor, since how long, age of onset, whether it is acute or chronic, then associated jaundice, abdominal distension, history of passage of dark urine, history of any drug intake, because as you know that in cases of G6PD deficiency, there is usually a culprit that is present, or there is history of a preceding viral infection that has led to the immune hemolysis. So history is very, very important. And then dietary history is very important to rule out the nutritional anemias. If the patient is nutritionally deficient, then nutritional anemia can be considered. Then family history of blood transfusion, like in cases of, most of these disorders are the hereditary disorders. So in cases of thalassemia major and sickle cell disease, and you usually have a history of transfusion in the family, other siblings or the family members. Then comes the history of consanguinity, and cousin marriages are more associated with the autosomal recessive disorders. Then comes the history of injection of drugs to rule out G6PD or immune hemolysis. In examination, we'll look for the degree of anemia, degree of jaundice, abnormal facies, like in cases of thalassemia, there is because of the extramedullary hematopoiesis, there is a prominent facial bones like the frontal bossing, parietal bossing, maxillary and mandibular hyperplasia, and dental abnormalities, which leads to the abnormal facies if they are not properly treated. Then hepatosplenomegaly, lymphadenopathy, signs of cardiac failure or the anemic failure to look for the severity of the anemia, whether it is acute hemolysis or chronic hemolysis. Investigations may we start with the CBC with the peripheral smear, and then reticulocyte count, direct Coombs test, HB electrophoresis, genetic testing, osmotic fragility test, and the enzyme levels. Now, this is a list of investigations which will go if you are suspecting the hemolytic anemias, but obviously we will do it one by one and gradually depending on the history examination and the initial CBC and peripheral smear findings. Like, for example, if a patient is presenting to you with a history of transfusion, history of months and presented first at the age of 6 to 7 months, he is severely anemic on examination. Now, on the history, first we do the history, and history, it is revealed that there is a history of consanguineous marriage, and there is also a positive family history of transfusion in the family, and the one of them is also affected. Then we should think of hemoglobin, and then we order the investigations. First of